Visible.
Right. Okay.
Yes,
Okay.
ma'am.
Yes.
Harish, can we start?
Yes, sir.
Are we live?
No, sir. 1 minute, sir. It's rerouting. 1 minute.
Okay.
Yes, sir. Start.
Yeah.
Okay, Tejasvi, please proceed.
Yes. Good morning. I'm Dr. Tejaswini, consultant medical oncologist. Today we'll be discussing regarding oncological emergencies and how to manage them in the point of in the critical care point of view. So, firstly, introducing what is oncological emergencies. Generally, for understanding oncological emergencies, they are life-threatening medical complications which are related to cancer and its treatment mainly, and which require immediate intervention. It may occur anytime from the course of malignancy, from the initial diagnosis to the end-stage disease. And what is its relevance in the critical care? Many of the oncological emergencies may present in the ICUs and require critical care expert analysis and treatment. So that's the reason why in the critical care, oncological emergencies is very important to know. And what are the impacts on patient's outcome? It improves the patient's survival rates, affect the quality of life, and for long-term prognosis and recovery also. So generally having a basic idea of what all we are going to discuss. So oncological emergencies might be caused by before the diagnosis of cancer, only through the signs and symptoms, and through paraneoplastic syndromes which are associated along with the cancer, and structural complications due to the cancer, and other like complications of chemotherapies or cytotoxic therapies which will be given, and complications of targeted therapies also nowadays. And also for pain and palliative care is one of the part in oncological emergencies. So common emergencies which we see generally are hypocalcemia, tumor lysis syndrome, and febrile neutropenia. Febrile neutropenia is the most common oncological emergency which is seen in leukemia patients. So febrile neutropenia around 80% is common for patients with hematology and chemotherapy in hematology patients, and hypocalcemia around 30, and then tumor lysis syndrome around 20% of patients generally we see. And what are the trends and patterns generally we see is with lung cancer patients, most commonly what we see is SVCO, that is superior vena cava syndrome, and obstruction, and mesothelioma, lung cancer, lymphomas, they commonly present with effusion, that is a pleural effusion. And metastasis to bone occurs most commonly with prostate. And in multiple myeloma, the common oncological emergency which we see is the spinal cord compression. And the objectives of this presentation is to identify and recognize common oncological emergencies which occur in the critical care setting, and so that we can understand the pathophysiology and apply this evidence-based interventions in the management of oncological emergencies, and to implement appropriate monitoring and assessment strategies for patients. And coming to the oncological emergencies, what are we are going to discuss in these two sessions? We are going to discuss metabolic complications, which are some of the most common emergencies which we regularly see. Neurological complication like spinal cord compression, brain mets, and then some of the meningeal carcinomatosis also comes as a neurological complication. And we also discussed regarding some psychiatric complications, cancer, pain, some renal, respiratory complications. So we have divided all the complications based on system wise to discuss in two parts. And coming to metabolic emergencies. So metabolic emergencies mainly are hypercalcemia of malignancy, tumor lysis syndrome, SIADH, and hypoglycemia. These are the most common metabolic emergencies. There are some other miscellaneous also. So we will be deeply discussing regarding these particular things because these are the most common things which we see regularly. So in hypercalcemia of malignancy, what is hypercalcemia in malignancy? So normally also the calcium, whenever the range is about 10.5 milligram per deciliter, or 2 points above the normal range, then it's known as the hypercalcemia, and it is classified as mild, moderate, and severe. So the prevalence data is in breast cancer, we see about 5 to 10% of cases presenting with hypercalcemia of malignancy, and in lung cancer about 20%. And generally the incidence in cancer patients, common complications which occur in cancer patients are around 20 to 30% of cancer patients are affected by hypercalcemia. And there is also higher incidence in cancers like breast cancer, lung, and multiple myelomas also. So the pathophysiology behind hypercalcemia in malignancy is increased bone resorption and intestinal calcium absorption, and decrease in the renal calcium excretion, which causes calcium to be increased in the blood, and then the levels of calcium increases. And osteolytic metastasis, like direct bone invasion by metastatic tumors, osteoclast activation, and typically seen in cancer and multiple myeloma. So tumor production of parathyroid hormone related peptide, which is something similar to PTH, and it leads to increased calcium release from the bones and the common squamous cell carcinomas. And the other one is vitamin D secretion. Some tumors, they produce vitamin D, like how we also see sarcoidosis associated with that. In that way, some of the cancers also produce vitamin D, and increased intestinal absorption of calcium. And these are most commonly seen with some kind of lymphomas. So coming to types and classification of hypercalcemias in malignancy, one is paraneoplastic syndrome, which we see. So as a result of cancer without any bony mets, if a cancer is there and then there are no bony mets, but the calcium is very high, then we take it like a paraneoplastic syndrome. So here the calcium metabolism is affected. It is most commonly seen in cancers like squamous cell carcinoma of lung, renal, and ovarian cancers. Local osteolytic hypercalcemia, here directly the tumor invades into the bones, and there will be osteoclast mediated bone resorption. And predominantly, mainly, we see this kind of osteolytic hypercalcemias in metastatic breast tumors whenever it is affecting the bones. And humoral hypercalcemia of malignancy. Here we see hypercalcemia occurring due to factors like parathyroid hormone related peptides, cytokines, and calcitriol. Generally, we see these in commonly in affected with lung cancer or adrenal carcinomas. And ectopic production of calcium that occurs very rarely, that is associated with cancers. Most common cancer is again lung in this kind of scenario. And generally the symptoms which we see with hypercalcemia is like with any other hypercalcemia itself, like neurological, gastrointestinal, renal, and cardiac manifestations like headache, migraine. In gastrointestinal, we have both nausea, vomiting, as well as constipation or diarrhea, and polyuria, polydipsia. And cardiac, we have arrhythmias and palpitation syndromes. And diagnostic criteria. So for the diagnosis, we have serum calcium levels will be checked, both ionized and total serum calcium levels, and adjustment to albumin levels. And reference range for hypercalcemia, we take as a diagnosis. And differential diagnosis to be done importantly for hypercalcemia of malignancy with hyperthyroidism distinguishes from malignancy related hypercalcemia, assess vitamin D levels, toxicities. And we also must consider granulomatous diseases like sarcoidosis to be ruled out. And role of parathyroid hormone and parathyroid hormone related peptide, both of them should be measured, and difference between primary and secondary hyperparathyroidism and implicated in malignancy related cases. So the imaging studies, whatever we do, are from the basic X-rays to MRI, we use based on the necessity there. So immediate treatment goals will be like hydration and diuretics at the first. We give loop diuretics, enhance calcium excretion, and bisphosphonates, calcitonin, and dialysis. For the first initial step for any hypercalcemia, once identified, the step one is hydration and diuretics. Second step is calcitonin. Calcitonin will immediately get down the calcium levels as quick as possible, because of which we give calcitonin. And if calcitonin is given in an injectable form, that is more better if it is available and the patient is affordable for that, or else we can go for subcutaneous calcium also. Third is bisphosphonates. Bisphosphonates act by inhibiting the osteoclast-mediated bone resorption. So bisphosphonates are another very important thing for immediately getting down the hypercalcemia of malignancy. The last one is dialysis. We generally use only whenever the kidney has been already damaged completely, and then the calcium is like very refractory to reduce after using calcitonin, bisphosphonates, and continuous hydration also. And for the long-term management, we generally go with denosumab and corticosteroids also. So corticosteroids have a role in decreasing the intestinal calcium absorption, and common steroids generally what we use are dexamethasone or prednisolone. And for denosumab, it's a rank ligand inhibitor. So we always have a doubt regarding for hypercalcemia of malignancy whether to go for denosumab or bisphosphonates. So we will see regarding that in the next. So the doses, generally we give excessive hydration, and for zoledronic acid will be 4 mg ideally, but we generally titrate it with the levels of the serum creatinine. So if the creatinine clearance is less, zoledronic acid dose is to be titrated and altered based on that. Denosumab, we give 120 mg subcut every 4 weeks, and 2 additional doses will give 120 mg subcut during treatment of days 8 and 15. Calcitonin 4 to 8 units per kg subcutaneously or IM will be given. And for steroids, hydrocortisone 200 to 300 milligrams IV every day for 3 to 5 days. And prednisolone 10 to 40 mg per oral every day for additional 5 to 7 days will be given. And when we go for whether bisphosphonates or denosumab, so there is a pooled analysis published. It's the recent study, whatever is there. Out of all the 8 studies were taken, and then a pooled analysis of that was done. Whether bisphosphonates is better or denosumab is better for hypercalcemia of malignancy. So if there is mild hypercalcemia of malignancy, it will get settled with hydration. Whenever there is a moderate hypercalcemia of malignancy, both chronic and asymptomatic or mild asymptomatic, then we will approach it like a mild hypercalcemia of malignancy only. Whenever there is acute increase in the serum calcium, or if the patient is asymptomatic also, along with hydration, sometimes denosumab will be recommended over no treatment given. Whenever it is severe, then we start with calcitonin initial treatment, and then adequate hydration will be given. In refractory or recurrent hypocalcemias, generally we suggest denosumab much better. And there are some special populations with high calcitriol levels also. In that case, we generally give hydration, and glucocorticoids are preferred. Whenever there is hypocalcemia with high calcitriol levels, first initially we prefer along with IV fluids is glucocorticoids in this sector. Generally, glucocorticoids will not be immediately given until in hypercalcemia of malignancy, until unless there is a special need for that. Whenever there is any inadequate control, like severe or symptomatic hypercalcemia, then we suggest adding either denosumab for that or bisphosphonates for that. And for during parathyroid carcinomas also, because in parathyroid carcinoma, there is alteration of the calcium and there is alteration of the vitamin D levels also, because of which we generally go either with IV bisphosphonates or denosumab. Inadequate control with calcium mimetics, then we again go with denosumab after the IV fluids, or we can add some calcium mimetics for that. So based on this pooled analysis, the final conclusion is bisphosphonates are to be used more commonly, and denosumab we can use it only when in kind of special population, and glucocorticoids also we will be requiring only when there is associated high vitamin D levels also. And coming to the next metabolic emergency, that is tumor lysis syndrome. So the risk factors and pathogens, like there is high tumor burden and rapid cell turnover is a definition for the tumor lysis syndrome. And chemotherapy sensitive malignancies like leukemias and lymphomas, they are the most common ones who are associated with tumor lysis syndrome. And mainly the pathogenesis involves a mass of cell lysis leading to the release of intracellular contents. That is the thing which we see in tumor lysis syndrome. So early recognition and diagnosis is more important for tumor lysis syndrome, and because of which the therapeutic strategies to be started as soon as possible with allopurinol or rasburicase, and aggressive hydration and urate lowering agents will be given. And in severe cases of tumor lysis syndrome, patient need to be taken up for dialysis. So high risk of tumor lysis syndrome are seen in some of the few of the cancers. So the most common cancer which is seen with tumor lysis syndrome is Burkitt's leukemia or Burkitt's lymphoma. Generally, usually whenever we give the chemotherapy for this patient's Burkitt leukemia or lymphoma, we be very careful with the tumor lysis syndrome parameters. We generally do all the metabolic parameters which are increased in tumor lysis syndrome twice in a day, morning and evening, for in case of Burkitt's leukemia or lymphoma, because usually it occurs in Burkitt's lymphoma. Generally, whenever it occurs with increased LDH levels, there is a high burden of tumor lysis. Apart from Burkitt's lymphoma and leukemia, we also have other leukemias like ALL, AML, lymphoblastic lymphomas, T-cell leukemia or lymphoma. So these are some of the few cancers where we again see tumor lysis syndrome. Out of all these, T-cell leukemia and lymphoma is again one of the rare kind of tumor. In adults, it occurs more commonly in children, and it is associated with tumor lysis syndrome, which is which generally appears in a very severe manner, because it generally is often seen in the last stages. Like, we don't notice it generally immediately, and it increases within few days, and then we see it in the last stages. And other than these, we have a high risk of tumor lysis syndrome with mantle cell lymphoma, and diffuse large B cell lymphomas, and CLL. In CLL, again, whenever we treat with venetoclax, that is BCL2 inhibitor, it's a medicine which inhibits the BCL2 in the cell cycle. And for CLL, generally to decrease the counts, we generally go with that, and we go with the hydroxyurea. During that time, there may be tumor lysis syndrome. So for the score which we generally use for tumor lysis syndrome is Cairo-Bishop score. So for Cairo-Bishop score, we take some tumor-related risk factors and some patient-related risk factors in calculation, and we proceed with laboratory TLS, and we proceed with clinical TLS. So for the tumor lysis syndrome, Cairo-Bishop score, intrinsic tumor-related risk factors are high cell proliferation rate, high-risk cancers, large tumor burden or bulky disease in lymphomas, that is more than 10 centimeters, and chemosensitive tumors. Whereas the patient-related risk factors are pre-treatment increase in uric acid or increase in phosphorus, pre-existing nephropathies, oliguria, and inadequate hydration for the patient. So these are all the risk factors for patient from the patient point of view for the tumor lysis syndrome. So we have two categories. One is a laboratory TLS, and another is a clinical TLS, which is defined by the Cairo-Bishop definition. So for the laboratory TLS, we should have 2 or more of the following parameters within 3 days prior or up to 7 days after the initiation of any cytotoxic systemic therapy. That is the uric acid more than 8 milligram per deciliter, potassium more than 6 milliequivalents per liter, phosphate more than 6.5 milligram per deciliter, and for children, and 4.5 for adults, and calcium less than 7 milligram per deciliter, or any of these values, they change 25% above from the baseline, or for calcium 25% below from the baseline. And for the clinical TLS, we have laboratory TLS plus one or more of these following should be there. That is, creatinine should be 1.5 times the upper limit of normal, any cardiac arrhythmias, seizures, and sudden death. These are all included under clinical TLS. So, so this is the pathogenesis of cancer cell lysis and tumor lysis syndrome. Firstly, after the cancer cell lysis, there will be hypocalcemia, ECG changes in arrhythmias, which also cause paresthesias, muscle cramps, and tetany. And whenever there is nucleic acid breakdown, that is a purine catabolism, hypoxanthine, xanthine oxide, and as we know, uric acid is increased, and then hypercalcemia will be there, which again changes into the arrhythmias, paresthesias, weakness, and then hyperphosphatemia, which causes secondary hypocalcemia, renal failure, seizures, and rhythm abnormalities. So the medications commonly which we use for cancers, this tumor lysis syndrome, after the hydration is xanthine oxidase inhibitors, that is allopurinol or febuxostat, and rasburicase, which is a uric acid inhibitor. So the differential diagnosis which we see, we have to compare with other conditions like chronic kidney disease, hyperparathyroidism, or any electrolyte imbalances which occur due to medication side effects. These are the DDs which we need to rule out when we are suspecting tumor lysis syndrome. And the diagnostic tests are the common complete blood picture. Main important diagnostic tests which we generally do for tumor lysis syndrome when we are suspecting is we do a levels of serum electrolyte panel, calcium, and phosphorus. And some imaging studies like renal ultrasound is done. Whenever the tumor lysis syndrome parameters are very high, we generally go with the renal KUB to suspect any kind of obstruction. Then when we go for the tumor lysis syndrome risk categories, so initially the risk stratification used to be there only with the LDH levels and patients total leukocyte counts, but later on later on the scores, the recent scores added by patients' age, stage of the disease, histological aspects, and anti-tumor therapy, whatever is the chemotherapies which we are giving, and the cytotoxic agents and biological therapies which we are giving, and the kidney function also. So based on all these, patients are broadly categorized into three risk categories for tumor lysis syndrome. High risk are more than 5% of the patients in all developing a TLS, and intermediate risk patients, 1 to 5% of these patients develop TLS. And in the low risk, less than 1% of the patients in the low risk category, they develop TLS. So the most commonly, whatever we have seen, out of all, Burkitt's lymphoma and leukemia are the first most common things for tumor lysis syndrome. And CLL, AML, and ALL, they all come under high, low, and intermediate risk. And this categorization is based on level of leukocytosis and LDH levels. And coming to the pharmacological interventions, generally we see is giving allopurinol, phosphate binders, rasburicase, and hyperkalemia. So rasburicase is indicated whenever there is a high tumor burden and rapid tumor lysis, and we need to monitor uric acid levels during the treatment of rasburicase. And hyperkalemia, use of potassium binders and diuretics, implementing emergency measures in severe cases, and regularly monitoring serum potassium levels is to be done during hyperkalemia management for this. And there is again another doubt for most of the patients that should we go ahead with allopurinol or rasburicase use during tumor lysis. So allopurinol we generally use whenever the renal function is completely normal. And there is like creatinine, uric acid completely normal. Only the uric acid levels have been altered and the urea is all fine. And rasburicase, we generally go whenever there is any discrepancy in the serum creatinine also. If the serum creatinine is high and the renal function has been altered, then we should go ahead with rasburicase. So immediately managing is with IV hydration. As usual with saline and bicarbonates, and correction, and magnesium and calcium monitoring is to be done very carefully, and renal replacement therapy only in severe and refractory cases of TLS. So the treatment different associated with TLS, generally we give allopurinol at 600 mg initially, followed by 300 mg per day IV, and rasburicase we go with 0.05 to 0.2 mg per kg IV. And for the hypocalcemia, calcium gluconate around 50 to 200 mg IV. And what are the potential complications which we see with tumor lysis syndrome are acute kidney injury, seizures and neurological events, and cardiac arrhythmias. So acute kidney injury is because renal function impairment due to rapid release of all the intracellular contents, and the kidney has been will be overloaded. It cannot take so much of load, so it enters into the acute kidney injury phase. And risk of hypercalcemia and crystal precipitation occurs in the renal tubules, and dialysis requirement is there only in severe refractory cases. And seizures and neurological events occur due to CNS toxicity because of the electrolyte imbalances like hyperkalemia and hypocalcemia. And also occurrence of seizures as a warning sign. Apart from this, because of the electrolyte imbalances, the most common things always which occur are cardiac arrhythmia, and there may be onset of atrial fibrillation or ventricular tachycardia also. So we need to closely monitor the heart, the seizures and neurological events, and the kidney injury. And coming to the third most common metabolic emergency, that is SIADH. So SIADH, syndrome of inappropriate ADH hormone secretion. This is because of excessive release of ADH. Generally, we see not only in cancer patients, we generally see SIADH in many other causes also. Like there may be because of pulmonary diseases such as pneumonia, tuberculosis, or whenever there is any use of medications like anticonvulsants, SSRIs. But usually in chemotherapy, we see with few of the chemotherapy agents which we give, and also we also see in cancer patients with few particular diagnoses, usually which we see with small cell lung cancer is a remarkable thing which we all study since our early stages of medical education. And that is one of the most common. Apart from this, adrenal tumors and some other tumors also produce also cause SIADH. So in SIDH, there is abnormal water retention, which is leading to hyponatremia. So the pathophysiology is increased antidiuretic hormone, which binds to the renal collecting tubules, because of which there is enhanced water resorption in the kidneys, and dilutional hyponatremia occurs, and there is suppression of aldosterone production in a negative feedback mechanism. So in cancer patients, these are the usual mechanisms by which SIADH occurs. One is directly induced by the tumor. Tumor releases excessive ADH from the cells, and ectopic production occurs in certain malignancies, and sometimes there is direct invasion or compression of the hypothalamus or the pituitary gland by the tumors. And chemotherapy-induced SIADH is because of cytotoxicity, which leads to ADH release from non-tumor cells, and chemotherapy drugs affect the HPA axis, and sometimes the side effects of specific chemotherapy agents causing ADH imbalances. And the paraneoplastic syndromes, production of ADH-like substances by the cancer cells, and immune responses stimulated by the cancers causing ADH dysregulation, and alteration in the body's endocrine function because of malignancy. So these are the mechanisms which we see in SIADH in cancer patients. So clinically, when we see the common SIADH is soaked inside, whereas diabetes insipidus is dry outside. This is the synonym we generally think of. And symptomatology, most common symptoms which we see in clinical practice are patient presents with nausea, vomiting, headaches, and severe cases showing confusion, seizures, and hyponatremia is a key clinical feature for this. And we have to, because these things have an impact on quality of life, and we need to differentiate from the non-oncological SIADH. So how do we differentiate? That is because rapid onset of symptoms occurs due to cancer or treatment. More severe electrolyte imbalances occur in oncology patients, which will be refractory. Most of the oncology patients who present with SIADH generally usually be refractory to fluids. So overlapping symptoms with cancer-related conditions. So here what we do is we do fluid restriction and limiting intake of free water, and regularly assessing the patient's hydration status, and electrolytes to be monitored. And pharmacological interventions mainly are introduction of diuretics for fluid overload and antihypertensive medications, but mainly until and unless we go for Vaptans. Generally it doesn't cause any correction in cancer patients. Most of the cancer patients, they require usually more than around 60 to 70% patients. Generally, SIADH becomes refractory and it requires Vaptans to be given. So long-term goals are monitoring, follow-up, patient education, and lifestyle modifications. So the role of Vaptans is very important. The action of Vaptans in managing hyponatremia is one of the common things. So coming to the neurological complications of oncological emergencies. So in neurological complications, a type of neurological complications are primary and secondary, which impact the quality of life and prognosis. Early recognition of these symptoms is important. So diagnostic tools for early detection are MRI and CTs, and statistics on the prevalence of different neurological complications. When we go ahead, we generally have most common neurological complication which we see in oncology is spinal cord compression. Apart from that, the other complications of related to neurology are quite a bit rare. We also have another neurological complication which we commonly see is the neuropathy in most of the chemotherapy related associated patients. But that is the usual common thing which we generally see in the OPDs more commonly. So common neurological complications which is required in the critical care point of view, these are brain mets, spinal cord compression, and meningeal carcinomatosis. Out of which spinal cord compression is the most common neurological complication generally we see in the critical care. So early warning signs and symptoms of spinal cord compression are very necessary. That is loss of bowel or bladder movement. And diagnostic approach is mainly by MRI neurological examinations. And brain mets treatment includes surgery, radiation, or chemotherapy will be decided based on that. And for meningeal carcinomatosis, main diagnostic is LP and CSF analysis. And some therapeutic strategies also we can give by giving intrathecal chemotherapy or radiation for the meningeal carcinomatosis. So the pathophysiology behind these neurological complications is for brain metastasis, there are some biological processes involved in the spread of cancer to the brain, and which leads to blood-brain barrier crossing and metastasis into the brain, and interaction between metastatic cells in the brain microenvironment. The most common treatment which we use for brain mets is initially always the radiation most commonly. Apart from the radiation therapy, we can go with the SRS also. And pathogenesis of spinal cord compression, this tumor growth, it may be an external compression or then internal compression also. And sometimes the molecular cellular mechanisms also, which underlie the compression, leads to the spinal cord involvement. And development of meningeal carcinomatosis, generally meningeal carcinomatosis occurs whenever any tumor spreads into the CSF, and then it may involve the whole of CSF and the sheets of the spinal cord. That is mechanism by which cancer cells infiltrate the meninges, impact of the meningeal carcinomatosis on the CNS also. So the brain metastasis, what are the common symptoms which occur whenever there's any brain metastasis? The headache, increased intracranial pressure. So suddenly patients present with sudden progressive headache which worsen over time, nausea, vomiting, blurred vision will be seen. And focal neurological deficits which we see are weakness and paralysis of specific body parts, speech difficulties, and depending on the brain area which is affected, and difficulty with coordination and balance. And there might be seizures also, that is generalized seizures or partial seizures will be seen. So coming to spinal cord compression may be external or internal, and the common symptoms which we see are with spinal cord compression are back pain, motor and sensory loss, and bladder and bowel dysfunction. Most of the common presentations which we see with spinal cord compression in the critical care part is the bladder and bowel dysfunction. Patients who are on chemotherapy or whose disease is progressed, they generally have this spinal cord compression, and whenever they present in the OPDs, they present with bowel and bladder dysfunction mainly. And meningeal carcinomatosis, we commonly see is cranial nerve palsies, radiculopathy, or altered mental status is the presentation for meningeal carcinomatosis. So when we go with the intracranial and extracranial symptoms, intracranially for meningeal carcinomatosis, generally we see with cranial nerve palsies, headache, vision changes, seizures, nausea, gait disturbances, and there are no apparent symptoms other than this. And for the extracranial, we see lower extremity weakness, gait disturbances, bowel bladder incontinence, reduced deep tendon reflexes, cervical radiculopathy, and sometimes there is no symptoms also. They may present asymptomatic totally. This is a slide from the NCCN guidelines of cancers. So here for carcinomatous or lymphomatous meningitis, usually the risk status, whether good risk or poor risk. So good risk are having good performance status, no major neurological deficits, minimal systemic disease, and reasonable systemic treatment options if needed. So for the good risk patients, we generally consider CSF flow, and then consider placing a ventricular catheter and subcutaneous reservoir, and involve field RT to the bulky diseases. Usually in India, we don't practice using any ventricular catheter subcutaneous reservoirs for the CSF. What we do practically is we generally go with CSF analysis, and then we generally give some intrathecal chemotherapies. A few chemotherapies which work intrathecally will be like methotrexate or methotrexate is one of the most common thing which we give intrathecally. And sometimes in case of cancers like breast cancer is one of the most common thing which generally spreads to the lymphomatous or carcinomatous meningitis. In that case, what we do is we generally give the targeted therapy also through the CSF or the LP. And this involved field RT is also given to the whole of the tract of CSF. And for the poor risk, that is low performance status, multiple or major neurological deficits being seen, or extensive systemic diseases with few treatment options, and bulky CNS disease and encephalopathies, here we generally consider fractionated external beam RT to symptomatic sites. So summarizing this for lymphomatous meningitis, practically what we do is we do the CSF analysis and LP. Once the carcinomatous cells are proved in the CSF, then we generally go with the intrathecal chemotherapy, and then the radiation to the whole of the brain and spinal cord CSF. And other one is apart from the radiation, we also try with the targeted therapies if the patient is having any targets available in the genome. So the imaging techniques we generally use usually is MRIs and PET. CT is very rarely used, but it is the one which, as we know, it's a first imaging and immediate technique in emergency situations. So CSF analysis, lumbar puncture, CSF cytology, and some biomarkers are done in CSF. We need to rule out other causes because most of the carcinomas which we have, they'll be in the older population. And in the older population, whenever they have any alterations, CNS alterations like delirium or confusion, usually it may not be only because of having a cancer-related symptom. It might also be because of Alzheimer's disease or any other symptoms. So we need to rule out those through CSF biochemical markers. So the biopsy is, whatever we do is, firstly, if it's a single lesion, we go with stereotactic brain biopsy. Spinal biopsy or leptomeningeal biopsy not most commonly done in India, and we generally go with the CSF analysis. So the surgical interventions commonly used are craniotomy for brain mets, and but most of the craniotomies for brain mets cannot be a complete removal of the tumor. Near total excision of the brain tumors are done. So because of which, after that, we need to then address them with the radiation and chemotherapy. And decompressive surgeries for spinal cord compression and endoscopic neurosurgeries. So whenever we have a patient with a neurological symptom or a spinal cord compression, so we consider giving corticosteroids in the first go. So initially, we generally give them corticosteroids, and then if the patient is a surgical candidate, a young patient having spinal cord compression, then we try to go ahead with a surgical intervention, or else if the life expectancy is less or the prognostic scoring is not much, then we generally think if based on life expectancy more than 3 months or more than 6 months or more than 2 years, if the life expectancy is more than 3 months, we generally go with interventional procedures. Like very few interventional procedures like radiotherapy or radiosurgery. If the radio sensitive, then we go with the radiation, or if it's resistant, we generally think of going with SRS. If it's more than 2 years, then interventional procedures are more effective than using only steroids and managing the patient with radiation. So what are the radiotherapy parts which we use for neurological complication is whole brain radiation is given, stereotactic radiosurgery, and spine stereotactic body radiotherapy. These are the categories of radiotherapy which are generally being preferred. And coming to chemotherapies, we have multiple chemotherapies which we use, like systemic chemotherapy for neurological complication. The response rates and benefits are usually better. Mainly whenever there is any meningeal carcinomatosis, we generally go with intrathecal chemotherapy. And targeted agents and immunotherapies are used based on the targets. For example, in a patient, as we have discussed earlier, a patient of breast cancer with meningeal carcinomatosis, we generally go with giving targeted agents. If the patient is HER2 positive, then we give targeted agent through the CSF, and combining targeted therapies also with the other chemotherapies which we give, like intrathecal methotrexate. And cytarabine is another drug which we generally give intrathecally. So managing this treatment and side effects also may require chemotherapies for that. And coming to the psychiatry emergencies in oncology, basically this is just to have an idea about whatever psychiatric manifestations generally usually we come across in our OPDs and in the ICU sometimes whenever in addressing a patient of cancer. So the patient-specific risk factors, what we need to check are the psychological history and comorbidities, age and gender differences, and treatment-related risk factors like side effects of chemotherapy and radiation. Any psychological impact of surgical intervention is there. And about the patient's past history, whether children, adolescents, or elderly patient with carcinoma. So acute anxiety, recognition of symptoms is important, and immediate intervention is required through breathing exercise, mindfulness techniques, and short-term anxiolytics to be given. And whenever there is any severe depression which could be addressed in the by the psychiatrist, then we think of identifying severe depression. Risk assessment for suicidal ideation is required, and crisis management strategies like ensuring patient safety and supervision is required. And delirium, usually most of the cancers which we see, the psychiatric manifestation would be delirium. And acute onset of confusion, fluctuating levels of consciousness, disorientation of time, place, and person, and hallucinations. These are the common symptoms which we see in the cancer patients in the psychiatric point of view, and underlying causes of oncology like metabolic imbalances. So whenever there are these, then we need to address regarding any metabolic imbalances present, like electrolytes and other metabolites to be checked, and medication side effects, infections or sepsis to be seen, and treatment and management approaches like identifying, treating the underlying causes, and antipsychotic medications to be given. And standard diagnostic framework. Standard diagnostic, which we see is DSM-5 criteria for mental health disorders, it will be followed. And consulting recent clinical guidelines and updates, we generally update it with that. And we need to rule out other psychiatric conditions also for the patient. And role of multidisciplinary team is required in this kind of scenario. So we generally use SSRIs, SNRIs, and benzodiazepines, and emergency medication protocols. We generally go with psychiatric medications or mood stabilizing agents. And psychotherapy, that is the cognitive behavior therapy, is most common technique which we use. Crisis intervention techniques and supportive psychotherapy is required. And palliative care is also one of the part of oncology. So we generally go with the palliative care, always focuses on the quality of life, pain and symptom management, patient and family centered care, and coordination with the critical care teams and integrative approaches in crisis is required. So cancer pain management. Cancer pain is one of the very important part in oncological emergency because most of the patients of cancer, they present with pain, like unknown pain due to cancer. So understanding the pathophysiology, cancer pain generally occurs from tumor growth, tissue invasion, chemotherapies, or some inflammatory process and nerve damage, which leads to pain precipitation. And we need to understand the nociceptive and neuropathic components of the cancer. And cancer pain is defined as pain which is associated with the disease and its treatment. The types of cancer pain may be either somatic, visceral, or neuropathic pain. They have a lot of impact on the quality of life. For chronic pain, psychological effects like depression and anxiety are seen, and social implications like withdrawal. And because whenever the patient is having persistent or severe pain, they generally withdraw from the treatments most of the time. So classification is acute pain is a short-term pain, generally due to surgery or any procedures. Chronic pain is persistent or recurrent pain over extended periods, and it is associated with ongoing cancer progression and require long-term management and support. Breakthrough pain is the one which transiently occurs. Intense pain, despite we are giving a baseline pain control is being given to them, and unpredictable onset will be there, and it is usually rapid, and it just settles immediately after giving a breakthrough pain medication. And incidental pain occurs sometimes, where it's like common in cases with bony metastasis or any like movement related injuries. So the assessment of pain is important. For the assessment of pain, there are multiple scales, out of which most commonly which we use are the Neumer rating scale 0 to 10, visual analog scale, and the McGill pain questionnaire. These are the things commonly used for assessment of pain in cancer patients. So generally we take a comprehensive history regarding the onset, duration, intensity and frequency of pain, and what are the exacerbating and relieving factors of pain. So coming to the pain management, we generally do the pain management in a step ladder pattern. Initially, we go with non-opioids, mostly like giving a paracetamol or use of NSAIDs or acetaminophen. It's for mild pain, and because if it's subsiding with non-opioids, then we generally go with the first part of step ladder pattern. Next, in case if it is refractory to these, then we go with the step 2, that is a weak opioids like codeine, tramadol. These are being used, or we'll go with the tramadol with combination of acetaminophen. And these are indicated for moderate pain, and sometimes combination with non-opioids will be given. Non-opioids which we use generally in a step ladder pattern of pain is going for neurolytics, that is neurolytic agents, which we go with. And sometimes we also go with SSRIs or SNRIs also in cases of pain which is of moderate level. And whenever the pain reaches to a peak level, or whenever there is any a third step which we go with strong opioids, that is like morphine, fentanyl. It is generally indicated in severe pain, and the risk of because we generally give morphine or fentanyl in the last level because the risk of dependency and tolerance with morphine is very high. And even then, if the patient is suffering with severe pain, we generally schedule the morphine or fentanyl at a frequency intervals. And in between, we generally give some IV formulations for immediate intractable pain reduction, that is breakthrough pain reduction. So this is the analgesic ladder which we follow for pain management. So we also give other medications, as I have already told, regarding antidepressants, anticonvulsants, and sometimes steroids also. Steroid has anti-inflammatory properties, because of which it is generally used in cancer pain and acute pain crisis. Steroid is one of the very important thing which we use in breakthrough pain. And some psychological support also is required. And common side effects which we have to take care is opioids is constipation, nausea, vomiting, sedation, and cognitive impairment will be there sometimes. And whenever there is overdose of opioids, it may lead to respiratory depression also. So we need to watch out very carefully whenever we are going with any kinds of morphine or fentanyl to the patient. We generally need to have a good observation on them for respiratory depression. And opioid-induced hyperalgesia is one of the common side effect which we generally see. So for them, generally we give analgesics. What we use are generally related to neurolytics. And adjuvant-related side effects, antidepressants, anticonvulsants, corticosteroids, these all have side effects. For antidepressant, the common side effects are dry mouth, weight gain. And for anticonvulsant, we go with dizziness, fatigue, and weight gain. And corticosteroids, as we know, hyperglycemia, mood changes, osteoporosis. These are the common side effects. And urological emergencies. So uro-oncology emergencies, generally we see are common scenarios are hypercalcemia, spinal cord compression, urinary obstruction, and these require immediate intervention. So the mechanisms which leads to the emergency situation are the tumor growth and local invasion into the urology system, that is the kidney, urinary bladder, and in the prostate. And complications from treatment like chemotherapy and radiotherapies. And this may have impact on the renal system organs. So common types of emergencies which we see are urinary tract obstruction, hematuria, sepsis, and acute kidney injury. So the imaging techniques as we use are ultrasound, CT, MRI, and X-rays. And we generally go with blood test and urine test most commonly. And tumor markers like a prostate-specific antigen is required in case of CA prostate. And the interventions which we do are scopies, that is cystoscope, and then to diagnose bladder conditions such as tumors and infections. It can also be generally whatever we see with renal is not before the cancer is diagnosed. For the urological system malignancies which cause any emergencies, we generally find out an emergency after the patient enters the critical care, and then we evaluate further. There might be an incidental finding of the malignancy by either knowing a history from the patient regarding the symptoms, or by any of the procedures, because they go very unincidentally, unknown, and we find out regarding them only when we to start evaluating them. So management strategies, what we do are medical and surgical management mainly. So for medical management, we generally go with normally the things which we increase the urinary flow. And for surgery, we generally go with the emergency surgery and minimally invasive techniques, and catheterization procedures will be done. And these are the, lastly, these are the latest oncological emergencies which we see. So the cancer therapeutic agents which cause cell growth, apoptosis, and stress response. So these are for the targeted therapies. So the targeted therapies usually cause some oncological emergencies, either the immune-related adverse effects, which we generally commonly are seeing nowadays with immunotherapy, because immunotherapy use is on a rise nowadays. We have immune-related side effects, most common ones seen. And for small molecule inhibitors, we generally see QTC prolongations, hand-foot-mouth syndrome. And CAR T-cell therapy, we see myelosuppression, hypogammaglobulinemia, and immune-related neurological symptoms, and cytokine release syndromes. And sinusoidal occlusion syndrome is generally seen with most of the ADCs. So these are the latest oncological emergencies which we are seeing because of the high rise of use in immunotherapies and targeted therapies. So in the next oncological emergency session, we will discuss regarding the respiratory complications, cardiovascular complications, and the gastrointestinal complications of oncological emergencies. Thank you.
Shyam?
Srinivas. Thank you, Tejasvi. I think it was very, very comprehensive to the point. I think of late, the incidence of cancers has gone up, and many a
Yes.
time in general intensive care, especially people who don't deal with malignancies often. Many a time we get patients with unexplained multi-organ failures, and then subsequently we realize that probably the patient would have fit into one of the onco emergencies. I think that that's something that we see very often,
Yes, sir.
especially with the hematological malignancies. So I have, I think it was a very comprehensive overview of what, even if you're not working in oncology setups, these are the things that we should be aware of, because you never know which patient comes to you, either a known or an unknown patient with malignancy may turn up in your ICU.
Yes.
Thank you,
Yes.
Dr. Tejaswini. Thank you, Dr. Tejaswini. I think it's important for non-oncologists to know the nuances of oncotherapy and the complications, because the field of oncotherapy has gone beyond what it was even 5 years ago. And with the advent of gene mapping, gene therapies, and of course artificial intelligence, it is becoming a fine art. So
Yes, sir.
every patient who comes under oncotherapy treatment needs to be supported by other specialties, and it is important that we understand the perspective. The kind of nihilism we had 10 years ago, or the negative attitudes we had, I think should stop. And this is an important area where non-oncologists should learn and try to be a little more practical in how they approach this patient. So we'll again have this session, the remaining half, next week. If you have any queries, please do send them on the group from where you got this link from, and we will try to answer them at their earliest. Please join again next week for the part 2 of this very interesting and relevant topic. Thank you all. Have a good day.
Thank you. Thank you,
Thank
Tejasvi.
you, sir. Thank you, sir. Thank you, sir.